Bismillahirrahmanirrahim. So, hello everybody. A 40-year-old woman's come to the emergency department due to nausea, vomiting, and dizziness. The patient has been unable to tolerate any oral intake over the last 2 days. She has had no fever, chills, diarrhea, or constipation. She reports no sex contact. The patient has a history of migraine for which she takes daily preventive treatment, but she has been unable to take her medication for the past several days due to nausea. Her last menstrual period was approximately 8 weeks ago, and she has a history of irregular menses. Temperature 36, blood pressure is 90/60, and pulse is 112 per minute. BMI is 32 kg. Physical examination showed dry mucous membrane, decreased skin turgor, and prolonged capillary refill. The abdomen is soft and non-tender. Pelvic examination shows a 12-week size uterus and bilateral adenxal masses. Pelvic ultrasound shows a uterus filled with a multiple small cyst but no embryo. The ovaries are 10 cm bilateral with a multilocular cystic appearance. Urine pregnancy test is positive. Which of the following is the most likely mechanism of this patient adenxal pathology? Excessive intrauterine androgen conversion, extrauterine implantation of a developing blastocyst, failure of follicular rupture during ovulation, ovarian hyperstimulation from abnormal trophoblastic proliferation, somatic differentiation of primordial germ cell. So first of all, we have this 40-year-old patient with having severe nausea, vomiting, and dizziness. Second, she having her last menstrual period approximately 8 weeks ago. 8 weeks ago. This is the second hint. The third hint is that she having on physical examination she having a 12-week size uterus and bilateral adenxal masses. Third hint. The fourth hint is that on ultrasound she having the multiple small cysts but no embryo. And the ovaries are 10 cm bilateral with multilocular cystic masses. Cystic appearance. So based on these 5 hints, what is the diagnosis of this question? So a patient having severe nausea, vomiting, and dizziness. Her last menstrual period was 8 weeks ago, and on physical examination she having 12-week size uterus on ultrasound and bilateral adenxal masses with multiple small cysts, and the cyst is multilocular cystic appearance. So the diagnosis of this question is complete hydatidform mole. The diagnosis of this question is complete hydatidform mole, and the patient is suffering from hyperemesis gravidarum because the abnormal trophoblastic hyperemesis gravidarum because abnormal trophoblastic proliferation secrete elevated level of beta HCG, which causes the nausea, vomiting, and dizziness. So here the correct option is choice D, ovarian hyperstimulation from abnormal trophoblastic proliferation, because this patient present with hyperemesis gravidarum and enlarged uterus, 12-week size at 8 weeks of gestation, and bilaterally enlarged ovaries. A presentation concerning for a complete hydatidform mole, a type of gestational trophoblastic disease. A complete hydatidform mole result from abnormal fertilization of an empty ovum by either two sperm or one sperm that subsequently duplicates its genome. The resultant trophoblastic tissue secrete high level of beta HCG. The elevated beta HCG level causes hyperstimulation of the ovaries and formation of thecoid lutein cysts, which are large bilateral and multilocular ovarian cysts. Now come to the choice A. Why choice A is incorrect? Excessive intra-ovarian androgen conversion, which is a polycystic ovarian syndrome and which is associated with excessive intra-ovarian androgen conversion and present with anovulatory oligomenorrhea, hirsutism, and multiple small ovarian cysts. Choice B. Extrauterine implantation of a developing blastocyst and ectopic pregnancy, which is a pregnancy. The blastocysts implant outside the uterus, typically in the fallopian tube. Ectopic pregnancy typically present as a unilateral adenxal mass. Choice C. Failure of follicular rupture during ovulation. So, a simple cyst occur when a follicle fails to rupture during ovulation. Simple cysts are unilateral or unilocular on ultrasound. Choice E. Somatic differentiation of primordial germ cell. So a benign cystic teratoma, that is dermoid cyst, is a tumor composed of differentiated germ cell. Teratoma can be bilateral but have both solid and cystic component. Teratoma are usually asymptomatic and are not associated with a hyatiform mole. Now come again to the choice D. Why choice D is the correct one? Ovarian hyperstimulation from abnormal trophoblastic proliferation. Because this patient is suffering from, this patient has a diagnosis of a hyatiform mole, and with the single sperm or the two sperm ovulate and which secrete the elevated level of beta HCG, which causes this patient nausea, vomiting, and dizziness. And this patient has a hyatiform mole because she having the last menstrual period 8 weeks ago, and she having 12-week size uterus and bilateral adenxal masses with multiple small cysts without embryo, and she having a multilocular cystic appearance. So here the diagnosis is a hyatiform mole, and the patient is suffering from hyperemesis